So I really feel for you guys as planners and designers. It feels to me like you've really got this deep commitment to human-centred design, yet your buildings, the projects you're working on, are facing resilience challenges and emissions challenges that they've never faced before. And then, how will I say this? If I got the vibe from yesterday, perhaps you're finding funding, approvals, or mindsets that could best be described as inflexible. I'm not sure if I picked up that vibe or not, but let's see over the next 9 minutes if I can provide you with a pathway through all that. So the reason we focus on this is the worldview on indoor air quality within hospitals and outside is changing, not because a bloke like me says so. Engineers will tell you that the way we used to do things was dilute, bring in territory language shitloads of outside air, and that does keep our spaces very healthy. The challenge, of course, is that it drives energy, it drives emissions, and it drives costs, capital and ongoing. So where the world is moving to is continuing to dilute, but minimising that element, and decontaminating the rest of our air. What do we mean by that? So we're not just talking about infection control, that is the baseline, there's no getting away from that. No one is suggesting for a moment that we decrease health. But we're talking about, in Queensland and the Northern Territory, mould destruction. We're talking about Canberra, Tasmania, Victoria, South Australia, and bushfire smoke, tobacco smoke, other elements of outdoor pollutants that, frankly, the world has put up with. We no longer need to do that. So I'm going to get technical for like 60 seconds. Stay with me. So ASHRAE 241 is only 2 years old. That's why probably most of you have never heard it. Simon, I know, has heard of it. The Lucid boys may have heard of it. But it effectively says that communicable diseases spreads when a susceptible person inhales a sufficient number of active pathogens to cause an infection. What it's really saying, and this is no surprise to infection control, is it's as much about dosage as it is poison. So if we can lower the amount of pathogens, bacteria, mould, viruses, then we end up with safer air. Let me drive through here. So what it's trying to solve is long range, and it says, yes, you can do it with outdoor air. It's fine. Continue that way if you want to. But crucially, we will recognise now clean air that is provided either because you capture the pathogens, filtration, really high-grade filtration, or you destroy them with air cleaning. Our device does both, but put that aside. You can use other devices to do it. You must, crucially, meet performance standards and safety standards. So that's a desperately important aspect, but the standard is technology agnostic. We're going to have a HFG conversation, or we can deal with that in the questions. I'm sure that'll come up. But this standard is now global. It is completely voluntary. It is not mandatory in Australia. Yet, as an example, as of last week, there was some talk about Green Star half an hour ago. The GBCA put out their Green Buildings version 1.1. They have adopted the ASHRAE standard as a permissible pathway. The IWBI, International Well Building Institute, has already had it in there for 12 months. So this is coming. We're a little bit slow on the uptake, but it is on its way. Why does that matter? It matters because instead of bringing in enormous amounts of outdoor air at 33 degrees or at 3 degrees, or enormous amounts of humidity, or enormous amounts of mould, the energy impact drops. So we're either maintaining or improving health at the same time as reducing energy. Oricon or Lucid will tell you if you work in South Australia, Victoria, Queensland or New South Wales, then you are going to be referencing 2 and 6. It's a very common ratio, 2 outdoor air changes, 6 total air changes per hour. It's in every single one of the state standards, except for WA. We should have a conversation in WA. But take the logic of ASHRAE 241 and apply it here. We still bring through the 2 outdoor air changes. Nothing changes there. We still bring in the 2 outdoor air changes. But the 4 other air changes, the rest of that air is now being cleaned or filtered or both to such an extent that it is considered the equivalent of clean air. So think about an emergency department, which is commonly provided as 100% outdoor air. It now has the chance to go 33% outdoor air and 67% equivalent clean air. And going back to our electrification presentation this morning, the engineers will tell you if you keep my outdoor air at 33%, it is so much simpler to electrify that emergency department because my peak load has not increased to 100, ERV or HRV, even with that. So what does it mean for patients and staff? It's a peer-reviewed study. This is from the Adelaide Women's and Children's down the road. It's 3 years old now. It's published in the International Journal for Public Health. If you can improve the air quality to that extent, 2 and 6 to 6 and 6, it is a 5-fold risk reduction for patients and staff. We're not playing at the edges. 5-fold risk reduction. It's a fundamentally healthier environment. People, let's talk about people. That's what we're here for. That blue line, Queensland Health Facility, that is through F8 filtration, G4 and F8. It's what is used in, let's call it 70 to 80% of the space of the hospitals that you design. Operating theatres, out here, HEPA, well established. Everything else, broadly speaking, the standards are different across the states, are between G4 and F8. They should be reducing contaminants by about 90%. In reality, we have now done projects with Queensland Health, Liverpool Hospital in New South Wales, Adelaide Women's and Children's in South Australia, and where my colleague is in Echuca today with the VHBA. In every circumstance, we are seeing these sorts of rates. That averages out at 38%. I won't go through the detail of why that occurs. But that means, if my maths is correct, 62% of those contaminants are getting through to our patients, to our staff. The HEPA standard, actually above the HEPA standard, is the orange line. That's the result that was actually achieved at Queensland Health. And I'm from the Territory. That looks like bullshit. It looks like I've just taken an orange texter, right? So let's zoom in. That's a real data set. Yeah, this is UniSA data as opposed to, University of Adelaide. That's a criminal offence saying that. University of Adelaide data, not our own. But the key here is, let's ask ourselves, do we want our nurses and our doctors in that environment with the orange? Or do we want it with the blue? Do you want your kids in the blue or the orange? Do we want, most of us are of a certain age, our elderly parents in an air environment with the orange or the blue? That choice is in front of us. It's actually quite a straightforward choice, I think. So Queensland Health, when they approached us, didn't really have this as their goal. They care. When I have conversations with different states, Queensland Territory talk to me about mould. So let's have a look at what happened with mould. The existing G4s and F8s had 1,012 mean fungal structures. We can have a conversation outside about what mean fungal structures mean. But every cubic metre of air had 1,012 mean fungal structures in it. Independent data, not our data. We got that down. We took out the F8s. We put our devices in. We got it down to 1. Let's talk about viruses. When we talk about viruses, they're remarkably difficult to capture in the air. It's just a scientific fact, ridiculously expensive. So academics use virus-like particles between 0.3 and 0.5 microns, just very, very small. Think about it like that. This is in the blue, pre-filter F8, in the orange, post-filter F8. 8.6 down to 6.5 million. It's not a bad job. It's, they're pretty small particles. When we tested, it was 13 million before our device. We got it down to 707. Let's talk about bacteria particles. Same principle, hard to measure consistently, so let's use the particle size. 2.7 million down to 1 million, or the median at 1.3 to 440. 2.6 million from memory, there you go, 2.6 million. We got it down to 12. Not 1,200, not 12,000, not 12 million, 12. The conversation is about what we want our air to be like. The biggest disadvantage of working in the industry in which I deal with is you can't see this. You can see it in data when we present it after the fact. Let's play a quick game. We've got our particle counter out there. We've got our device out there. How many particles in the air, in every cubic metre of air? Just someone shout out a number. How many particles? We'll go with 1 million. Put your hand up for 1 million. 2 million. 5 million. some for 5 million, 10 million, a couple at 10 million, 15 million, 20 million, 25 million. Sir in the brown jacket, 25 million. So there's 25 million particles in the cubic metre in front of me right now, possibly. It was pretty crowded back there, maybe a little bit less. Not all of those are infectious. I'm not trying to scare people. Some are. Some are. And if we go back to the environments that we're creating, the operating theatres are fine. You know, I'm sure they can be improved, but they're fine from an indoor air quality point of view. But fundamentally, if I'm an oncology patient, if I'm a dialysis patient, anyone who's got cancer in their family has lived through this, severely immunocompromised, and in our hospitals, you'll never guess this, there are some pretty sick people. So they are coughing and splutting and talking and putting these particles out. So again, I ask you, blue line or orange line, which would you prefer to design for? Okay, Victorians, they don't care about mould. South Australians don't care about mould. They do care about bushfire smoke. So another peer-reviewed peer-reviewed article, gas phase odours don't have particles. Smoke's a bit different. It's tiny. It'll go straight through HEPA because the particles are very, very small, smaller than the 0.3. But also they'll be gas phase. By that I mean they're like methane or CO2. They don't have a physical substrate to them. So they tested on odours, and we did not expect this result. We're very proud of it. We're effectively 3 times more effective for bushfire smoke. The Victorians are desperate to understand this. They have pulled money out of their pocket and they're putting us into a chuka in a regional asset to test this. Because you are hospitals, you will bring in outside air. No one's trying to reduce the amount below the minimum. But that minimum is going to, in a regional context, in New South Wales, in Victoria, in Canberra, in South Australia, it's going to have bushfire smoke, whether it be burn-off or whether it be an actual bushfire event. So we need to design this from a resilience perspective. I won't take you through the odours, but we get rid of all that. For the engineers in the audience, how are we achieving these energy savings? So firstly, we're reducing the amount of outdoor air to the limit, to the AUSHFGs or the state-based guidelines at the 2 and 6. But where we have some advantage, and there are other technologies you can use, but generally speaking, the world has moved beyond conventional HEPA for this sort of achievement, and you can see a clean static pressure of 120. That matters. This chart is too lengthy for today, but if you're building an emergency, it is now cheaper to do it with decontamination than it is to do it with outdoor air and HRV. I'm sure you're all sitting there going, does he know we're architects? Rather than engineers. So let's bring it back to the one thing you can do. This is the engineering world, there's no question. I'm not suggesting you become experts in this subject matter, but I do encourage you to include this in your brief. You can get your phones out and take a photo if you like. We've got an expanded version if you come to the desk around the corner. But really all you need to ask, Mr. or Mrs. Engineer, is to say, the design team is requested to assess and present options for enhancing airborne infection control in accordance with emerging international best practice, including the principles of ASHRAE Standard 241. It's really straightforward to do. I started with budgets and people-centered design. I think so much of this game is mindset, How we approach problems and how we approach new solutions and how we get them embedded into things like the AUSHFGs, the CIRs in Queensland, the VHBA and the New South Wales HI. Ladies and gentlemen, thank you very much.